Good afternoon. Thank you for the opportunity for presenting to such a wide and varied audience around the world. And I am going to take you on a whistle-stop tour away from the inland sea that is emergency medicine, everything that we've been talking about today. I've got no conflicts of interest to declare before I launch into this talk. So a bit about myself. I CSER'd in emergency medicine in 2021. It's a parallel path towards becoming a consultant within the UK, and works very well for people who wish to stay in one locale as opposed to being posted around different geographic locations. During that time of CSERing, I managed to study and acquire a postgraduate diploma in sports and exercise medicine. I was lucky enough to work with the women's hockey team who won gold at the Olympics in 2016. I've worked with various football clubs. I was honoured to work alongside the military at Headley Court, looking after wounded service people on their way back from foreign military action. I currently have a small 60% role in the NHS, and the rest of my time is spent outside of the NHS, so I get to see both sides of the coin. And with a recent political transition, it's a very interesting time indeed, I think, where we all sit within emergency medicine. So we talk about sepsis, we talk about Reboa, we talk about trauma, we talk about head injury and bleeding. And these are all things that we are familiar with as part of our practice in emergency medicine. But of course, within the UK, we are having to increasingly become the masters of things that we wouldn't traditionally think that we're becoming masters of. So we know that primary care is really underfunded here in the UK. I'm not aware of what it's like in other parts of the world, in Egypt, in the Middle East, and Australia. We know there's a significant drugs and alcohol burden within our department. We know there are significant mental health issues out there in society that we form the basis of their routine support for in the emergency department, unfortunately. There are chronic conditions that are poorly managed by the community, and indeed the community have no answer for. And these form the revolving door patients. And on top of that, we have a pandemic of frailty on our doorsteps as well. Also something that we have to be worried about. But this talk is going to be mainly aimed at a group of patients that sits within this red box. And there's a lot of overlap between all of these patients. And I guarantee you that we will all at some point in our emergency medicine careers pick up cases, the next case, and it will say one of these conditions on the right-hand side, and inside we'll let off a little bit of a sigh. Oh, not another one of these. What can I do with this? There's no magic wand for it. I don't want to encourage drug-seeking behaviour. What is it actually that drives these people to see us in the emergency department? Within these conditions, what we get is a plethora of complaints and symptoms that patients will have in common. So almost all of these patients on the right will have dysregulated sleep. We all know the effect of dysregulated sleep on us as emergency clinicians. Our 4 a.m. decision-making isn't going to be as sharp as when we first started the night shift, for example. They'll be complaining to some extent of mood disorders, depression, anxiety. That may translate into IBS symptoms, migraines, functional neurological conditions, and nociceptive symptoms. The vast majority of them will defy laboratory investigation. Their blood tests generally will be boring. And we know this when the bloods are taken. We're doing it just to prove there's nothing extra that we're missing here, no extra zebra that hasn't been considered. So these patients eventually, they'll get sick and tired. They'll be in such psychological distress that a proportion of them will present to our departments in psychological extremists. They'll be self-harming. They won't have any other way of expressing their emotional distress. They'll take tablet overdoses. Name that arrhythmia. I think Hesham's going to cover that later, and does a good job of it in his course, I'm led to believe. And a very small proportion of them end up being intubated, all with, to the taxpayer, a socio-economic cost. How much is it that a patient who's intubated as a result of poor care out in the community for a physical or a psychological condition costs to society by an inpatient stay in intensive care. Moreover, what about the patients themselves? They don't get an answer from a healthcare service that's meant to provide them the care and the compassion that they so look after and want. But actually, what they get is medical gaslighting. They get told to pull their socks up. They get told there's no answer. They get told there's nowhere to go. No wonder these guys keep presenting to our departments. All of these different medications that they're on, is there not a better solution for it? All of these medications generally are one tablet, one receptor, one molecule type treatments. Is there nothing that can bring all of these together? We're all familiar with people that bring in carrier bags of medications to the department, and you're sifting through them, trying to wade through the smell of old cigarette tobacco and smoke in the bag, and you're trying to work out what's new, what's old. Is there not a different way that patients can be cared for, or a missing piece of the puzzle that we're missing in modern medicine that could bring all of this together? Is there something? And I'm going to throw this out there at risk of being a modern day William Harvey. So first, I thought I'd honour the talk with a little bit of a study, okay? Because it wouldn't be correct to talk about medical cannabis without some context. Because at the moment, there's a lot of stigma in the UK. There's a lot of stigma around the world, and certainly I know in the Middle East, you can't even transit with medical cannabis as a medicine in your checked-in luggage. So this study is a bit about something that we've all been very familiar with since it developed around the world in 2018. So this is an American study. It's looked at patients who were hospitalized with COVID over a whole calendar year. 95% of all US hospitalizations, so a massive number of patients that we can't ignore. The cohort was split into those patients who had cannabis use disorder as a diagnosis and those who didn't. Yes, it's retrospective, but we cannot ignore 1.6 million cases to look through. There are 13,000 of them who are cannabis use disorders. Looking at the numbers, and I think that the authors have jumbled up some of the numbers here. If you look through those numbers, you can see actually some of the numbers are higher for the cannabis use disorder group. But the conclusion is that in patients who have cannabis use disorder that are out there turning themselves into chimneys at any given point when they have a spare moment, if they had COVID, when they were in hospital, they had lower rates of NIV, lower rates of requiring RSI, lower rates of requiring ECMO, lower rates of sepsis, and lower rates of GI bleeding, as well as death. All the other comparators, there was no significant difference about. So that's just one little seed I want to plant there. And I want you to think, why is it that something that's just a street drug in a lot of places, and that's how it's conceived, can produce such a marked effect when it comes to a condition that we're all so familiar with and had almost no answers for when it first came out? Bonus points for naming these two individual men. But the point of this is that there's a whole culture out there around the recreational use of cannabis, which, just for the record, I'm completely against. I think there's a massive issue with the strength of it and how it's portrayed in the media. And I think a lot of the people pushing for the full recreationalization of cannabis don't take into account the soft underbelly of society that will be harmed by the full recreationalization of cannabis. The answer is Cypress Hill, if you're into that sort of music. So this next little bit of research is how cannabis and some of the compounds present within cannabis managed to switch off the cytokine storm that was a feature of vanilla COVID, as I call it. Okay, so I'm not a cellular biologist, so to translate a bit, LPS is a lipopolysaccharide, i.e. interleukins and prostaglandins that we know are responsible as cytokines in inflammation. we've also got this NLRP3 inflammasome. What does that mean? It's a group of receptors that are involved in chronic inflammatory conditions and the cytokine storm in COVID. So there's a lot of cellular biology involved in this paper, which gave me a bit of a headache. So I've taken away just a few snippets of it for you. There was a big section on how CBD and THC markedly reduce the levels of these inflammatory cytokines. These will be familiar to you. IL-6, TNF-alpha, these are medications that monoclonal antibodies were created in laboratories to reduce the levels of in conditions such as inflammatory bowel disease, rheumatoid arthritis, the interleukins involved in multiple sclerosis. Surprise, surprise, there is a medical cannabis treatment for multiple sclerosis. It's Sativex. Two cannabinoid compounds, CBD and THC, also reduce the generation of reactive oxygen species that we should all be familiar with that cause cellular oxidative stress. So in conclusion, the paper demonstrated and more discussed that COVID created this huge cytokine storm for us, and also at the same time prevented aspects of our immune system from switching off the cytokine storm, and thus postulated that in these patients who had cannabis use disorder and already had high levels of CBD and THC within them, they had a natural mechanism by which they could switch off this inflammatory cytokine storm, reducing the lung fibrosis and the need for ECMO and intubation and so forth. That was a hallmark of vanilla COVID when it first came out and how scary that was. So we've established, or I've argued for, a biomolecular pathway that cannabis can work in the human body as a therapeutic benefit. What about other areas? We know that cannabis has benefit in terms of reducing opioid burden in recreational users, and certainly in my practice outside of the NHS, I found I've been able to deprescribe high doses of tramadol, buprenorphine, fentanyl patches, tapentadol, you name it, oxycodone. And these patients come to me in clinic just zombified on gabapentinoids, tricyclics, and all these opiates. And gradually with time, these patients, they go back into education. They go back into paid work and paying tax. They go back into having meaningful relationships as partners and as parents. I've seen it with my own eyes that there's real benefit to it, and you get this palpable sense of genuine thanks from the patient. You've done something beneficial for the quality of their life, not just ticking it along. So in this case, there's a definite symmetry between opioid-induced analgesia and ECS-induced analgesia. Okay, they all modulate and activate similar channels within the human being. Indeed, cannabinoids also have a degree of overlap with opioid receptor activation. What's generally accepted now is that opioids are better for nociceptive pain, i.e. someone slamming a hammer on your wrist, and the cannabinoid system is better at dealing with neuropathic pain. And there's definite small papers and small prospective papers demonstrating that benefit. But what is this ECS that I'm talking about? What is the endocannabinoid system? We have an endocannabinoid biome within our body. In the same way that we have an adrenergic system, an opiate system, a serotonergic system, we have a cannabinoid system. So it's not just a bag of weed from the street corner that someone smokes to get high. Actually, we have receptors within our body that respond to endogenous cannabinoids that our body produces as a cellular communication pathway. So the other part that's really interesting is that the receptors within our body are older than the plant itself. Someone told me that the other day, which I find absolutely fascinating, that potentially the plants evolved to communicate with the human being or the cannabinoid receptor. So we produce our own cannabinoids. The two principal cannabinoids are called anandamide. Anandamide, translating roughly, is to bliss. Those of you who speak the language will understand that. 2-AG is the other principal endogenous ligand of the CB1 and the CB2 receptor. Exogenous ligands of the cannabinoid receptors, THC and CBD, those are very, very familiar with us by now. For those of you who knew that CB1 and CB2 are the main receptors in the human being, also know that there are other receptors that respond to being bound to by cannabinoids. So the GPR55 receptor, the TRPV receptor, and PPAR intracellular receptors all respond to being activated or agonized or antagonized by cannabinoids. We also have enzyme degradation pathways, which I won't go too much into because this is not a biochemistry lecture. So the endocannabinoid system is everywhere, okay? Principally, though, the locations that have principally been described are the CB1 receptor in CNS and spinal tissue, and the CB2 receptor principally in the periphery, mainly in the immune system, in the thymus, particularly on macrophages. And for me, the CB2 receptor is fascinating in terms of being able to modulate autoimmune conditions with cannabinoids that are present in food. So there's a cannabinoid that's present in black pepper. It's called caryophyllene. There are small studies that demonstrate it can modulate our immune system. These conditions of mast cell activation syndrome, idiopathic anaphylaxis, what is it that makes these mast cells dump their histamine? No one can seemingly understand it. Is this got something to do with reduced CB2 receptor tone on the macrophage? Just a question. Wiggly lines, lots of different colors. I apologize for the complexity of this, but again, this is another diagram showing how interrelated things like diet, gut microbiome, intranuclear receptors, exercise, meditation are with all of the different receptor subtypes. On the bottom here, you've got the main two cannabinoid receptors, the CB1 and the CB2 receptor. You've got the TRPV1, the transient receptor potential vanilloid receptor, which responds to capsaicin as an anti-inflammatory. You've got the GPR55 receptor, which is implicated in epilepsy, calcium-gated voltage channels. You've got serotonin receptors. But what I want all of you to take note of here, and this is key to the endocannabinoid system, is these heterodimers on the right-hand side. CB1 will co-locate itself with almost any other receptor. In this case, you've got a dopamine receptor, the D1 and the D2 receptor. Activating the CB1 receptor will also activate the dopamine receptor through a G protein coupled mechanism. And that is how the endocannabinoid system acts as a master homeostatic switch within the body. It's present throughout the body, and its absence in medical textbooks is absolutely criminal. But back to our departments. Let's bring it back out of the textbook, out of the Petri dish, and let's just put that into practice, okay? We've talked a bit about the cannabinoid, the CB1 and the D1 receptor heterodimer. Recently, Chris Humphreys produced this. He's a toxicology fellow, soon to CCT. I think he's still at St Thomas's in London. And he produced this, which is suspected cannabinoid hyperemesis syndrome guideline in our emergency departments at the beginning of the year. So we have to identify first what is cannabis hyperemesis syndrome. So generally, it's our story of cyclical vomiting in a patient who uses cannabis frequently, not just infrequently, and who benefits from hot showers, warm baths, hot water bottles to the point where they will develop erythema ab igne on their bellies quite frequently. And it's the only thing generally that aborts these really painful attacks. And typically, departments will throw every antiemetic, every painkiller at them in an attempt to abort this attack. There was a trial, which I haven't included here, which next time I give this talk I will do. It's called the Havoc trial. And it was haloperidol in a population of patients with suspected cannabis hyperemesis and compared it to ondansetron, and they showed that haloperidol was superior to ondansetron at 1 hour and at 4 hours. I think I could be wrong with that. But essentially, what we found is an atypical antipsychotic as a treatment for cyclical vomiting. So those of you in Australia will be very familiar, and one of my colleagues in Taunton loves droperidol for all of these reasons. Treats everything, agitation, vomiting, cyclical pain. But going back to the slide, why would a dopamine receptor antagonist treat cannabis-induced hyperemesis where all the other antiemetics don't work? It's because of this heterodimer. Okay. Does this mean that there are other heterodimers that we could investigate in terms of the management of other conditions that don't quite fit the mold of traditional treatment that we're used to here in the West? And there's a whole load of other heterodimers going on. Again, I'm not going to bore you with the cellular biochemistry of it all, but there is evidence of the CB1 receptor here and the G protein coupled receptor heterodimer. So CB1 with dopamine, CB1 with the opioid receptors, CB1 with adenosine, CB1 with the oxorexins and the grelins. So in terms of sleep, in terms of appetite, in terms of anxiety, in terms of managing ADHD, modulating immune, there are functions throughout the whole body that cannabinoids modulate. But why isn't any of this in our medical textbooks? Why is it just seen as a drug of abuse and a gateway drug and just an illicit substance? It's absolutely criminal. So what's the difference between street cannabis and medical cannabis? What is the main difference? So this was several years ago. Surprise, surprise, street cannabis contains dangerous amounts of fecal matter. Like with all illicit drugs, you just don't know what you're getting. Small study in Spain put cannabis resin, hashish, under a microscope. They found E. coli, they found aspergillus, they found bits of plastic in there. 40% of hashish had the aroma of feces. Not the nicest, especially if you're having to pay for it, right? So how do you take cannabis and make sure that it's of medicinal value? What turns it into a medicine? So here in the UK, I don't know about Australia, where it's also medically prescribed, we have the European Pharmacopoeia, and we also have means of testing each batch that's produced in big automated growing facilities around the world. Albania, Portugal are two such places because they match California's climate quite significantly. So this is something called a certificate of analysis. It's a really long document that's not important for this. It's just a sample of one. And what you can see is they test the cannabis, each batch of cannabis for heavy metals, so cadmium, lead, arsenic, mercury. They also look at the total anaerobic microbial content, the total yeast microbial content, and all of the other bugs that would make it unhealthy and unfit for human consumption, as listed by the European Pharmacopoeia. Each batch needs this in order to be passed for import by the MHRA. There's a minimum standard to come into the country. And so there's a very, very long story about the stigma and why cannabis was made illegal, mainly to do with the DEA in 1930s America. After alcohol stopped becoming illegal, they needed a new target. Fast forward all the way to 2018, and there were a series of parents who had to go abroad and seek medical cannabis oil for their children, who would frequently present to our emergency departments in status epilepticus. And by going abroad, getting their oil, paying their thousands, they would guarantee that their children wouldn't present weekly to their emergency departments in status epilepticus. I'm going to play this very short video of one of the mothers. If it doesn't play, can someone please tell me? Because sometimes when I share this video, it doesn't work.
For years, we've seen Charlotte Colvin and other mothers battling to make the government change the classification of cannabis, what's known as its schedule, so that it might be used to treat their children. And today, they won a major victory.
It's not satisfactory for the parents, it's not satisfactory for the doctors, and it's not satisfactory for me. I've now come to the conclusion that it is time
Oh, sorry, one sec.
to review the scheduling of cannabis.
Anna Deacon is one of those mothers. Her son Alfie suffers from a dangerous form of epilepsy.
Hold it in your mouth and they go 2 weeks.
She successfully reduced his seizures by treating him with cannabis oil. 3 months ago, she met the Prime Minister in Downing Street and was promised action. In the Commons today, Alfie was singled out.
Earlier today, the policing minister also spoke to Alfie Dingley's mum, Hannah Deacon, and informed her that we will issue a license for Alfie later today.
We spoke to Hannah Deacon just after that announcement. Her relief was clear.
I'm extremely overwhelmed. I mean, if I think about the many hundreds of times I took him into A&E in an ambulance, and I held him his hand. I mean, he's begging me to help him, and mummy, and cuddling me, and I just couldn't live like that. I just could not live like that, and I'm so grateful that he doesn't have to live like that anymore.
The announcement of a review means cannabis may soon be.
Those of you who are parents will know that's genuine. There's nothing fake about that. And for all of us that have been in a paediatric status epilepticus situation, you can only imagine the turmoil that parents are facing when they see their child in that situation.
Used as a.
So as a result of that change in 2018, here in the UK, we've now got a small number of clinics prescribing medical cannabis for patients who meet the criteria. They're all CQC regulated clinics. The medications all come in and have to be verified and authorized by the MHRA, and patients are discussed on an MDT basis. So, as you can probably tell, I feel very passionate about this. I could spend days talking about medical cannabis and all the different aspects of its prescription. What else could we talk about? We could talk about how cannabinoids and opiates have now been shown to play a part in the placebo effect. So and this actually links back into the theme of the day, because actually randomized controlled trials, you have an intervention or you have a diagnostic test or the intervention, and you rate it against the placebo. But actually now, evidence that I've seen suggests that people's baseline endocannabinoid and opiate tone can affect the degree of their placebo response, which can change in any other day because there's so many things that can regulate people's underlying endocannabinoid tone. So actually, does that bring into question randomized controlled trials and actually the nature of placebo-based trials? We always think that placebo just means nothing, nada, no effect. It's a nil response. It's something that's going to be something completely different from the intervention. But actually, if the placebo is always changing, does that not make us concerned that the results of these trials also aren't always going to be consistent inherently? What else could I talk about? I could talk about the role of cannabis in epilepsy and why it works so well, and why CBD as a molecule, as promiscuous a molecule as it is, works so well as a simple sodium channel blocker, as well as other aspects of anti-epileptic medication without the side effects of a valproate or a carbamazepine. But I want to leave you with a few more thoughts. Again, we're talking about randomized controlled trials. We're talking about very strict inclusion criteria. When we go out to the real world, and I'm really fascinated that all the talk today has been about the pyramid of evidence, but nowhere has been mentioned real world evidence. Does it really not matter because it's subjective reported that actually people's voices and the effect of these medications on them are completely discounted purely because it's subjective and self-reported? You look at some of the papers that we've discussed today, you look at the demographics, 90% are male and white. How is that translatable around the world? All these patients that we see have a plethora of really complicated conditions. They're on multitudes of medication. They would automatically be a part of exclusion criteria by and large, just because of the number of medications they've had. So how applicable are these really narrow, ecologically designed trials to the real world? Really, how applicable are they? And a lot of papers and a lot of critics of medical cannabis point towards a lack of RCTs. But I'll tell you, you cannot generate an RCT for a plant. It just doesn't work like that. And when you understand the botany of cannabis, you understand there are actually lots of different strains, of lots of other different compounds in it, which you can't control. Does that mean that we should disregard it completely just because there's no RCT data? We all know from our practice that people don't come to our emergency departments overdosed on cannabis. Yet all the other medications that are used instead of what cannabis could work for they do come into our departments overdosed, which was the whole point of the beginning of my slide. Do we not need to reassess how we look at human physiology to further understand and treat our patients better? Those are my last thoughts. Yes, they're controversial. Yes, it's different. Yes, it's away from true evidence-based practice. But there's a whole population of patients out there that are just going round and round and round that don't have an answer, that inevitably we see outside of traditional healthcare systems that really, really benefit from this. And there is a scientific background to it that's completely missing from our medical schools and our textbooks. And I just urge you to have a think about it, to have a look into it, to be curious, because it definitely works. I've seen it for the last 4 years in my own eyes. All the patients we almost loathe to see in our department sometimes are managed really, really well within this sort of environment. Thank you very much.